Neonatal jaundice is a common condition observed in newborns, characterized by the yellowish discoloration of the skin and sclera due to elevated bilirubin levels. Bilirubin is a waste product produced by the breakdown of red blood cells. It is normally processed by the liver, but in neonates, various factors may impair bilirubin metabolism, leading to jaundice. Pathophysiology. Jaundice occurs when there is an imbalance between bilirubin production and its excretion. This can result from increased bilirubin production, impaired bilirubin conjugation in the liver, or failure to excrete conjugated bilirubin. Unconjugated bilirubin. When red blood cells break down, they release heme, which is converted into bilirubin. This bilirubin is unconjugated, indirect, meaning it is not yet processed by the liver. Unconjugated bilirubin can accumulate in the blood when there is an overproduction or the liver's conjugating capacity is insufficient. Conjugated bilirubin. In the liver, unconjugated bilirubin is processed by the enzyme UDP-glucuranosyl transferase to form conjugated bilirubin direct. Conjugated bilirubin is excreted in bile. If there is obstruction or damage to the bile ducts or liver cells, conjugated bilirubin cannot be properly excreted, leading to its accumulation. Causes of neonatal jaundice. 1. Unconjugated hyperbilirubinemia. The most common cause of neonatal jaundice, often seen in the first days of life. Physiologic jaundice. In most newborns, physiological jaundice is common due to immature liver function and is typically seen after 24 hours of birth. It resolves as the liver matures. Prematurity jaundice. Preterm infants are at higher risk due to underdeveloped liver enzymes, which prolong bilirubin clearance. Hemolytic disease of the newborn, caused by blood group incompatibility, e.g. ABO or Rh, leading to excessive destruction of red blood cells. Congenital hemolytic disorders. Conditions like sickle cell anemia or thalassemia cause premature red blood cell destruction, resulting in elevated unconjugated bilirubin. Gilbert's syndrome, a mild genetic disorder where there is reduced liver enzyme activity, leading to intermittent unconjugated hyperbilirubinemia. Crigler-Najjar syndrome, a rare genetic disorder causing a deficiency or absence of the enzyme needed to conjugate bilirubin, resulting in severe jaundice. 2. Conjugated hyperbilirubinemia, caused by impaired excretion of conjugated bilirubin. Hereditary conditions. Dubin-Johnson syndrome and Roeder's syndrome cause defects in bilirubin excretion. Infections. Viral infections like hepatitis B, hepatitis C, and cytomegalovirus, CMV, can damage the liver, leading to conjugated hyperbilirubinemia. Biliary atresia, a life-threatening condition where the bile ducts are either absent or blocked, leading to poor bile flow and the accumulation of conjugated bilirubin in the blood. Ray's syndrome, a rare condition, often associated with viral infections and aspirin use in children, leading to liver and brain damage, resulting in elevated conjugated bilirubin. Clinical manifestations. Yellowing of the skin and sclera, the primary symptom of jaundice, usually appearing 2 to 3 days after birth. Feeding difficulties. Babies with jaundice may exhibit poor feeding due to lethargy or discomfort. Poor weight gain, associated with difficulties in feeding. Dark urine and pale stools, if conjugated bilirubin is elevated. In cases of biliary obstruction or liver dysfunction, urine may appear dark due to increased conjugated bilirubin excretion. Severe jaundice. If bilirubin levels are significantly elevated, the baby may exhibit symptoms of kernicterus, a rare severe form of brain damage due to bilirubin toxicity, such as poor feeding, high-pitched cry, muscle rigidity, or abnormal movements. Diagnosis. The diagnosis of neonatal jaundice involves the following. 1. Clinical examination. Jaundice is diagnosed by visual inspection and by checking the sclera, whites of the eyes. 2. Total bilirubin level. Blood tests to measure both total bilirubin and the breakdown into unconjugated indirect and conjugated direct bilirubin. 3. Coombs test, to identify hemolytic jaundice due to Rh or ABO incompatibility. 4. Liver function tests, to assess for liver dysfunction or disease. 5. Ultrasound, to check for biliary atresia or other structural liver issues. 6. Blood typing and direct antiglobulin test, D8, in cases of suspected hemolytic disease. Treatment and management. 1. Phototherapy. Phototherapy is the most common treatment for unconjugated hyperbilirubinemia. It involves exposing the baby to specific wavelengths of light that help break down bilirubin into a form that can be excreted via urine. Exchange transfusion. If bilirubin levels are dangerously high or if phototherapy is ineffective, an exchange transfusion may be required. This involves replacing the baby's blood with donor blood to rapidly lower bilirubin levels and prevent kernicterus. 3. Intravenous immunoglobulin, IVIG. In cases of hemolytic disease due to Rh or ABO incompatibility, IVG may be given to reduce the destruction of red blood cells. For treating the underlying cause. If jaundice is due to an underlying condition like biliary atresia, infection, or metabolic disorder, treatment focuses on addressing the primary cause. Antiviral treatments for infections like hepatitis. Surgical intervention, e.g. biliary atresia surgery. Gene therapy or enzyme replacement for genetic disorders like Crigler-Najjar syndrome. 5. Supportive care. Adequate hydration and nutrition are essential, especially if the infant is having trouble feeding due to jaundice. Interventions. Monitoring. Regular monitoring of bilirubin levels to ensure they do not rise to dangerous levels. Family education. Parents should be educated about the signs of severe jaundice and the importance of timely medical intervention. Lactation support. Encouraging breastfeeding helps the baby pass meconium, which assists in eliminating bilirubin from the body. Prognosis. Physiologic jaundice generally resolves without treatment and has a good prognosis. Hemolytic disease of the newborn requires immediate treatment to prevent complications such as kernicterus. Biliary atresia requires early surgical intervention and may require a liver transplant if diagnosed late. The prognosis largely depends on the underlying cause of the jaundice and the timing of treatment. Conclusion. Neonatal jaundice is a common yet potentially serious condition that requires early identification and appropriate management. Unconjugated jaundice is typically physiologic. Pathologic causes must always be ruled out to prevent complications like kernicterus. Timely diagnosis, treatment, and ongoing monitoring are essential in ensuring a positive outcome for affected infants. Clinical Case 1. Physiologic jaundice in a full-term infant. Case presentation. A 3-day-old full-term infant presents with mild jaundice. The infant was born at 39 weeks of gestation with a normal birth weight of 3.2 kilograms. The baby is feeding well but is slightly lethargic. The jaundice was first noticed at 24 hours of age and has progressively worsened. The mother is breastfeeding exclusively. Clinical findings: yellowish discoloration of the skin and sclera. Bilirubin level, total bilirubin 10 mg, indirect bilirubin 8 mg. No signs of poor feeding or weight loss. No history of blood group incompatibility or infection. This is most likely physiologic jaundice, a common condition in healthy full-term infants. It typically appears between the 2nd and 3rd day of life due to the immaturity of the liver's ability to process bilirubin. Management. Phototherapy. As the bilirubin level is elevated but not yet at a critical threshold, phototherapy is started. The baby is placed under blue light to help convert unconjugated bilirubin to a water-soluble form for excretion. Monitoring. Bilirubin levels are monitored every 12 to 24 hours to ensure they do not rise further. Supportive care. The baby is encouraged to continue breastfeeding, which helps in promoting bowel movements and the elimination of bilirubin. Reassessment. The bilirubin levels are rechecked in 24 to 48 hours to determine the effectiveness of phototherapy. Outcome. The baby's bilirubin levels drop significantly within 48 hours of phototherapy, and the jaundice resolves completely within a week. The infant is discharged after 5 days with follow-up instructions for routine checks. Clinical Case 2. Hemolytic disease of the newborn. Case presentation. A 2-day-old infant, born to an Rh-negative mother with an Rh-positive father, presents with severe jaundice. The baby was born at 38 weeks by spontaneous vaginal delivery with a birth weight of 3.4 kilograms. The baby is breastfeeding but appears lethargic and has not been feeding well. Clinical findings. The baby presents with severe jaundice that is visible across the entire body, including the palms and soles. Bilirubin level: total bilirubin 18 mg per liter, indirect bilirubin 16 mg. Positive Coombs test indicating hemolytic anemia due to Rh incompatibility. Signs of kernicterus: high-pitched cry and muscle stiffness. Diagnosis: the diagnosis is hemolytic disease of the newborn, HDN, due to Rh incompatibility. The mother's antibodies have crossed the placenta and attacked the baby's Rh-positive red blood cells, causing excessive hemolysis and elevated levels of unconjugated bilirubin. Management: phototherapy. Intensive phototherapy is started immediately to reduce bilirubin levels. Intravenous immunoglobulin: IVG is administered to reduce the hemolysis and further bilirubin production by decreasing the maternal antibodies attacking the red blood cells. Exchange transfusion: given the severity of jaundice and the presence of kernicterus risk, an exchange transfusion is performed to rapidly lower the bilirubin levels and remove the maternal antibodies from the baby's circulation.